Lovely. So, Mayank, go for it.
Okay, so good evening, everyone. So I'll be presenting the third case, which was left from the earlier presentation. So this baby was admitted at the time of birth for perinatal depression. The baby was intubated in the delivery room itself. So the gestation of the baby was 32 weeks by last menstrual period, and when we assessed by Ballard scoring, it was found to be around 36 weeks. So the birth weight was 2.2 kg, and the baby was born through vaginal delivery. There was a history of prolonged preterm pre-labor rupture of membrane. So the baby was on SIMV mode with pressure support. The peak inspiratory pressure was 16 with a PEEP of 6, and FiO2 was hovering around 30 to 35%. There was no respiratory dysynchrony. The baby was a little tachypnic between 60 to 70 rates, but there were no retractions as such. So I conducted this lungs ultrasound exam at 8 hours of life with a linear probe, and I used the Brad's method. I'll show why. So this was the X-ray which was obtained at around 6 hours of life. This basically shows the if I come directly to the lung fields. So there are the lungs are expanded adequately. I can see almost 7 to 8 rib spaces. There's some perihilar streaking which I can notice. So it which goes in favor of TTN. However, I also see some areas there. There's some air bronchograms which extend up to the margins, all on the lung margins. So I can see several air bronchograms. And since the FiO2 was hovering above 30, so there was a confusion that there might be a component of RDS as well, and we were confused if we should give surfactant or not. Since the assessed gestation was 36 weeks, we were not in favor of giving surfactant. So I primarily used the Bratz method. The caveat is I did it at 8 hours of life, while the ideal would timing would have been soon after birth, as was done in the initial study. So directly coming to the lung pictures. So this is the left part of the lung, the L1, L2, and the left lateral. So as can be seen in the L1 part, so probably the probe was not perpendicular, so I haven't got a clear pleural line. However, the pleura was moving okay. I cannot appreciate the nature of the pleura if it was abnormal or not. And I can see several B lines in multiple rib spaces, and these appear almost to be confluent. So I gave this a score of 2, and then I move to the L2 region. So I can appreciate a normal pleura which is sliding well, and there's a predominance of A lines. However, in one of the rib spaces, I can appreciate that there's more than at least three B lines which are extending up to the bottom part. So I had given a score of 1 in this case. And in the left lateral region, I can see again probably my probe would I think is not perpendicular. So the pleura is not so clear. But the pleura is sliding well, and there's a predominance of B lines. This almost the complete B profile that I can see here. But there's no subpleural consolidation as such, and I would score this as again 2. So coming to the right part of the lung, the R1, R2, and R3. So the in the R1 region, I can appreciate almost a normal looking pleura which is sliding, but there are some B lines which and some comet tail artifacts. There are some B lines which are extending sometimes to the bottom as well, and this is kind of B profile. And but I was confused if it was to be scored 1 or 2, but I had given a score of 1. Then the R2 region, I can see a pleural line which is sliding well. There's A lines, uh, and there are some cometal artifacts. I can see one or two B lines, but these are not more than three in a single space. So I had given a score of 0. Had considered this as A profile. And if I come to the R3 region, I can see this pleura which is looking normal and sliding well, and this A lines which can be seen, but there are also B lines which are more than three in number in a single space. So this is what I feel, that this is AB profile, and I had given again a score of 1. So the total score came to be 7, but I was not so confident if I had scored it the right way. This was the interpretation and reporting that I had used for reporting this patient.
So excellent. That's an absolutely fantastic presentation. So let's just go back to the history. And I think what is beautiful about this case is the fact that clinical correlation is a very important aspect of us doing lung ultrasound. And in particular, I think when we're doing lung ultrasound, what we're doing is we're doing lung ultrasound at one particular point of time. So what you're doing is getting a kind of a clinical picture of the lung, like an X-ray, where there is a lot of dynamic kind of change that's happening. So just when we focus on the history, I mean, this is a near-term baby with a Ballard score of about 36. The baby's been delivered by normal vaginal delivery.
Yes.
Mother was in good established labor.
Yes, yes, yes.
Okay. And I mean, why do we think the baby had perinatal depression? I'm just
So
curious.
the baby didn't cry at birth. We were not sure about the reason as such. Um, but the cord pH was not so bad. It was more than 7.2.
Okay,
So,
excellent.
but there was the baby didn't cry and required intubation as well.
Sure. And I mean, if you look at, again, the ventilation, we're not needing a huge amount of pressure support, PIPs of 16 with a PEEP of 6, an FiO2 that's about 30%. Significant recession, no retraction. So kind of, it seems like a baby who's kind of got well-supported ventilation on minimal settings with a little bit of tachypnea. Now, I'm
Yes.
just curious at this particular stage. So the lung ultrasound, I mean, 8 hours for this baby. What do you think about the timing?
So I feel that this was a little later than what would have been ideal. So I was initially since this was 30 after assessment, the baby was found to be 36 weeks. So we almost made a working diagnosis of TTN,
Okay,
and
so
and we were
fair
not
point.
thinking in terms of RDS as such.
Sure. So we'll have a look at the chest X-ray so that anybody who's joined late can have a look at it. So this is the chest X-ray, and I would agree that it looks like there's a kind of a little bit of a ground glass appearance. There is some air bronchogram, some reticular nodular shadowing, but then you do have fluid in the fissure over here. You have a little bit of a sharp margin there. There's thymus that's apparent. Whether there's a very sharp margin there, it's maybe a little bit of an pneumovirus times, tricky to say, but very nice kind of an airway that's visible at this particular point. Now, the most important thing that I'm going to take you through when I approach lung ultrasound is how you approach what questions you want to answer. And what I would say is that the first question for us as a diagnostic conundrum is what we're thinking clinically. So there's your clinical differential diagnosis. So there's RDS, there's TTN. What we do know, at least, if you work in the West, is that GVS pneumonia, or for that matter, sepsis, can give you a very similar kind of a ground glass appearance. If there's surfactant inactivation with that, you can even get air bronchograms. So there at least three common differentials at this particular stage for us to
Right.
consider. Now, the diagnosis should first hinge on lung ultrasound as a diagnostic tool to help us differentiate between these three conditions. That's crucial. So before I would kind of think of my scoring, what I'm really thinking of at this particular point is, well, how am I going to use lung ultrasound as a tool to try and make a differential narrow down into one of these three common diagnoses? I'd also, because this baby has respiratory distress, want to make sure that we don't have a pneumothorax in any particular region. And I think the third thing that's very important for me is then what I would say is the concept of serial ultrasound. Now, a
Okay.
lot of diagnosis that you will make, especially in term babies with RDS, and I'll be covering this on the 6th of February, is an overlap of a lot of lung ultrasound signs where there is a low sensitivity and specificity for some signs and a high sensitivity and specificity for a collection of signs, which then point you towards a diagnosis. So a very good example is I will be teaching you about the double lung point. Now, the double lung point is something that is helpful and has been quoted by authors to be very, very sensitive and specific in the diagnosis of transient tachypnea of newborn. However, recent studies actually show that it is found in less than 50% cases of transient tachypnea of the newborn. In fact, it can be seen in RDS. It can be seen in the phase where RDS is improving or post-surfactant. And in particular, it is not pathognomonic of TTN at all. Rather, what you're really looking for when you're trying to differentiate RDS and TTN is a few very important things. So the first thing would be a very smooth pleural line. And that, from my perspective, may be blurred, maybe a little bit thick, but it's smooth and regular. And that is a feature of TTN. You also won't get consolidations in transient tachypnea of newborn, which you will get with RDS. But more importantly, if you look at RDS, it's a very uniform kind of a disease. Now, if you look at this X-ray, fairly uniform appearance, fluid in the fissure there. But what you find is that when you look at the lung appearance, there is a very uniform appearance with the absence of any spared areas. So the presence of kind of co-located A zone, A lines, A profile with an AB profile transitioning is something that is seen more in TTN, whereas what you would see in RDS is more of a B profile, which I will explain. Now we'll go on to the videos because they're very nice, man, very nice videos. So what you can see in L1, which is the left anterior zone, is pleura that looks, I would say at this particular point, because of the resolution, it might look irregular. Actually, the sharpness and the reason that it's irregular is because your focus point. So have you zoomed in here, Mayank?
No, I didn't zoom in, but I feel that my probe probably was not so perpendicular. So it
Sure.
might have.
Sure. So
Mhm.
that's a possibility. But if I just critique this image, very nice. So we've got three ribs, two intercostal spaces. We've clearly got pleura that's visible, which is bright. There is pleural sliding. I think this pleura, if we'd kind of had a little bit of better resolution with focus at that margin, would probably be
Mhm.
visible like L2. And what you'd get is a very clear, smooth pleural line. What you've also got is complete B profile. So you've got B lines. So if you just use your marker with the middle B line, Mayank, and these B lines are fused together. These are basically what you call compact B lines. And these compact B lines, along with a regular pleura, at this particular point, give you a B profile. Now, that could be RDS, it could be TTN, but what I'm really thinking about is this pleural margin in L2, which looks really smooth. It looks really smooth. It's regular, it's bright. There are absolutely no consolidations in L2, and you'll have to take my word for it. But if you look at L1, just under the pleura, some people sometimes interpret this irregularity as subpleural consolidations. They aren't. They're actually just blurred pleural margin because of resolution of the probe. And the slightly dense features, if you just take that red marker just to the pleural line, slightly above, just to the pleural line, right at the top, these dense white kind of spots, which sometimes people confuse with, I would say, subpleural consolidations, they're actually less than 0.5. And in TTN, if you have these kind of appearances, actually, they would, they, I would not class them as subpleural consolidations. Again, if you go to L3, you have a B profile with compact B lines. This is a regular, nice pleural line. Again, it's a little bit blurred, which is why it's not giving you that appearance of L2. And I think the difference is your focus at the level of L2 is at the pleural margin, whereas at L3 and
Mhm.
L1, it's not. I think your probe is perpendicular, but I just think that you will have a button for focus. Now, one of the things that you could do to kind of make your margins a little bit better is on your machine, you'll have soft and sharp imaging. And if you use sharp, which is available on the GE, it will actually make your pleural margin nice and well defined. I think the
Okay.
only other thing I'd say, just when I critique this particular image, is that you could zoom out a little bit, which will give you a
Mhm.
slightly broader picture. You're using a hockey stick, are you?
No, no, no. I'm using a linear probe, and the footprint is around 2.5 or 3 centimeters. So it actually the part which is being shown is the actually the whole length of the probe. So I cannot. This is the maximum I can get. I cannot zoom out.
You can't
Means
zoom
I
out
can
from it.
zoom in, but I
Sure.
cannot zoom out.
Lovely. So on WhatsApp, Mayank, you're going to share with me
Mhm.
your probe.
Mhm.
And then
Okay.
what we will do is we'll talk about your machine, maybe in a one-on-one call, just to have a look at it and see how best you might
Oh.
be able to optimize resolution.
Mhm.
But
Mhm.
clearly, when you look at this particular image, my feeling at the moment is you've got B and you've got A, and you've got an area of complete virtual transition, normalcy in
Mhm.
L2. Now, that
Mhm.
for me, when I look at the clinical history of a baby with kind of that presentation, as well as the fact that you've got fluid in the fissure, I'm kind of getting a feel of TTN at this particular point. So
Okay.
I, I'm just giving you my feel clinically. What
Mhm.
about L2? What else can you see in L2? Anything else, Mayank?
L2, there's hard shadow, which is actually
Yeah, yeah,
interrupting the,
yeah, yeah.
and
So
then there's stomach and the OG tube
yeah,
probably.
yeah, very good. So what has happened is that you've got the heart shadow coming into view. So you've gone lateral. The one area of L2 that you kind of might have missed is medial to the heart shadow. And I've taken a video that I'll share with all of you on Tuesday next week, which basically teaches you how to interrogate partitioning when you're on the left side of the chest. So
Okay.
that is something that sometimes can prove challenging. Now, have you did you manage any of the posterior views, or
No, I couldn't.
no
No, no,
problems?
no. I
That's
didn't
absolutely fine.
actually test it
Okay.
completely.
So can you talk to us about the clinical course your baby took?
So the baby was so on day 3 we could extubate the baby, and the baby is now currently day 6 old, and the baby is on CPAP, but FiO2 requirement is 21%.
Hmm.
So there was a gradual decrease in the FiO2 requirement. It took more than 48 hours to correct. So retrospectively looking, I felt that there was a component of RDS as well.
And
So
you're
there was a delayed response.
absolutely, yeah, you're absolutely right to say that there's some authors who consider that there's an overlap between TTN and RDS in this particular situation. Did you surfactant the baby? Did you give the baby any Curacao?
No, no, no. We didn't give surfactant.
Yep. So, I mean, that's the only other thing to highlight, that term RDS, established term RDS, with pulmonary hypertension, is something that I would say may have an overlap with TTN. But again, clinically, what I would have done differently in this particular case to help make my diagnosis is I would have followed this case up with serial ultrasound. And serial ultrasound kind of means that when I'm confused, the best ultrasound to do is usually once you've stabilized the baby, got him onto the neonatal unit, and within the first 2 hours. So for a big term baby, once you've tube ventilated, got your lines in, really what you want to do is your golden hour sweep. And your golden hour
Mhm.
sweep is applicable to all babies, even babies with respiratory distress who are intubated. In that, what you're trying to do is basically get a feel of your anterior and lateral regions, right and left, to make sure that
Mhm.
you've got an idea of what the lung profile looks like. And then you follow that up and you do lung ultrasounds at 4, 6, 12 hours. And really, what you're looking to see is, are you getting double lung points? And I would say that at this particular point, I don't have any double lung points, but this is a baby who probably I would say is early in its course with
Mhm.
definitely spared areas. And that for me would go against RDS at this particular point. So
Okay.
it would be very, very interesting if you do serial ultrasounds to see whether you had a double lung point that appeared at any particular point of time. And it's just to give you an idea and a feel that in TTN, It's absent in 50% of cases, but once early TTN resolves and the fluid gets absorbed, you can see it appear, and you can see it appear in multiple places. So, interestingly, while it's not essential for diagnosis, what you're really trying to do is make a kind of a diagnosis through serial ultrasounds. What would give me a real feel that this would have been RDS is if I could see really good subpleural consolidations, and I can't see them anywhere at this particular point in either of these images. Any questions from the audience? So I'm just keen. I've got Sharif Dabar who's raised their hand. So Sharif, go for it. Yeah.
Yeah, well done, Mine, for the presentation. Excellent. And thank you, Alec, for the explanation. But just a quick question about the double lung point. I'm not. Can you explain it more? What you mean by the double lung point and the difference in between?
Sure. So the double lung point basically represents an area of transition. So what we know with transient tachypnea of the newborn is it's a condition where fluid, interstitial fluid in the interlobular septa of the lung is getting absorbed. Now we know that that gets absorbed at a differential rate. So there's good evidence, not just from studies in animals, but now lung ultrasound studies, which tend to show that the anterior portions of the lung in a supine baby, in particular the upper zones, tend to aerate first and better as compared to the anterior lower, the lateral lower, and in particular the posterior zones. So when you end up doing a lung ultrasound, and I'm going to get Mayank to kind of demonstrate it. So Mayank, L2. So you are going to go to that B line in the middle.
B line.
Yeah, perfect. That's perfect. So that's a B line, Sharif. Now, if you look to the right of that line, right towards the gastric shadow, what you can see is a B profile. So lots of B lines that are stuck together. So like a compact B line. But if you look to the left of this line, what you see is pure A profile. You can't see any B lines. Now this pattern where you can see a sharp demarcation between the upper and the lower parts of the lung field, this is what is called a double lung point. And the reason it's called a double lung point is because you see the sharp demarcation, which splits the lung field into an upper zone, which is predominantly a normalizing, well-aerated zone, and a lower zone, which has fluid. I think what I'd say is that this is probably a double lung point that is recovered. So I think if we'd done this maybe in about 4 hours, on the right of that B line, you would have had a complete B profile and you would have had a perfect double lung point. But trust me to say, I'm going to show you lots of double lung points when we cover transient tachypnea of newborn. I think what I would say to you is that it is no longer considered pathognomonic of TTNB. In fact, I've seen it very commonly when I've given surfactant to preterm babies, where you have areas of the lung, in particular, if you look at the right side of the lung, sometimes it gets more surfactant than the left. But in particular, the right upper lobe gets more surfactant. And what you might find is that the right side of the lung, upper lobe, gets more and better aerated, and you get a double lung point. For those of you who would like to see what a double lung point looks like, the latest video, I'll share the link with you, that has just been published on our YouTube channel, explains it beautifully and gives you a really good example of what it is to kind of differentiate the upper half, the sharp transition, the lower part. Does that help, Dr. Sharif? Yeah. So Dr. Hassoun, you have a comment. Please comment.
Yes. Hello. Thank you very much for your explanation, Dr. Alok, and thank you for the presentation. My feeling like with you, it's more favorable in TTN because the pleura is very smooth, no pleural consolidation. But just I will comment for L1 view. Is that if we want to score this one, it is a score of 1 or 2? Because for me, it's just one. Because the B line are not coalescent or compact like score. We saw it in score 2. I don't know what will be your comment, Dr.
So my gut feeling is you're right. It will probably score a 1. If I could give it a 1.5, I would. But I think from my perspective, to the actual score, like the overall score is 7. Now, this is a very important aspect. So let's just go to that scoring. Now, when we look at scoring, what is very important is we are going to use Bratt's method throughout. We are going to use and practice Bratt's method. We're not going to use any other lung scoring methodology. And the reason for that is there's no evidence to show that extended lung profile related scoring of the posterior zones actually lends any additional advantage. For me, it actually results in more handling, especially of extremely preterm babies. Now, a lot of us would say, well, if we're thinking of a clinical diagnosis of our transient tachypnea, why are we doing an RDS Bratt score in this baby? And I would say to you that there are two very nice papers that I'll be sharing with you, which actually look at lung ultrasound scoring in transient tachypnea of newborn. And what they're doing is trying to quantitatively analyze transient tachypnea of newborn and how it clinically improves. But if I take RDS, a score of usually 8 and above for this is considered kind of a score cutoff, which gives a higher probability that surfactant would be beneficial for treatment of a baby. Now, for TTN, this is not used for treatment per se or use of surfactant. We know that surfactant is not going to make a difference for these babies. But what we are using, the Bratt score or a scoring method, is to kind of quantify our progress. And a good example is if you did this score maybe at about 2 hours of age and you had complete B profiles in every zone, you'd have a much higher score. But if you repeated it in 3 hours and the scores come down to 2, that is rapidly aerating lung. On the other hand, for a baby with transient tachypnea, like clinical picture, who has a high score based on the profile, say maybe at 2 hours of age, who has significant work of breathing, there is good evidence to show that the scores actually predict respiratory failure. So, there is a group and a school of thought who actually do lung scoring for transient tachypnea as well, but not for treatment and use of surfactant, more to quantify the clinical course this baby might take and to kind of use it as a tool to kind of make a judgment, clinically correlating of how they might want to escalate treatment. I would say to you that clinical correlation here is absolutely key. My beautiful slide, I'm going to ask you to stop your presentation. And what we're going to do is we're going to go to Dr. Funny Priya. Dr. Funny Priya, are you able to share your presentation? We seem to have lost Dr. Funny Priya at the moment. I'm just going to see. Kirti, are you up and running?
Yeah. Mm-hmm.
Excellent. So Kirti, while Funny Priya is trying to prepare, are you happy to share your case?
Yeah, okay.
Lovely. I'm really grateful. Thank you so much.
That's okay. Is my screen visible?
Your screen is visible, but your share screen isn't. You're visible.
Oh. Now? Is it visible now?
No.
No? I don't know then.
You're struggling? Okay, so just if I talk you through it, so when you share your screen, it's allowing you to share? I've made you co-host as well. Let me just repeat that. Sometimes it blocks. So okay, have another go.
Now is it visible?
Oops, is it visible to anybody?
No.
No.
No, no, not visible.
Can I send it to you?
Is it images?
It's videos, but I've made it into a presentation. So
Will you
Oh,
email
good.
it? Yeah, it'll be a massive file on email. Don't worry. I think what we can do is you can share it with me by Dropbox, and maybe what we can do is we can do it with the next mentorship session. Is that okay?
yeah.
No
Okay.
problems. I'll give you a link to be able to do that. Does anybody have any other cases they'd like to share?
I can share mine, Luke, if
Sure,
that's okay.
absolutely. Yeah, pleasure.
So will I just share the screen or?
Yes. So
Let me open.
actually, Dr. Leila, I think Dr.
Yeah,
Funny Priya has shared.
sure.
Yeah,
Excellent.
thank you. Dr. Priya, we can't hear you. If you unmute yourself, you're muted. So just unmute yourself. Dr. Priya.
Sharing my screen, it is getting auto muted.
Okay, so just share your screen now.
I'll just try. Okay, it's showing one participant can share at a time. Someone else is probably sharing.
Okay. Leila, you're not sharing at the moment, are you?
Showing one participant can share at a time.
No, I'm not sharing.
I can't see that anybody is sharing at this point. Mayank, you've stopped share. I can see. Yeah.
Yeah, now I can.
Okay.
Nani వీడిని ఒకసారి తీసుకోవా?
That's great. Now we can see your screen. Yep. But you've muted yourself, so you'll need to unmute yourself, Dr. Priya. Dr. Priya, you've muted yourself.
So whenever I'm sharing, it is getting auto muted. I don't know why.
No problems. Okay, so let's do one thing, guys. I will be sending you a Dropbox link, which enables you to share your presentations in that. If they're, just make sure they're completely anonymized, and that way next class, I can actually share both your presentations. Is that okay?
Okay, thank you.
Yeah, that would be fine.
Lovely. Leila, go for it.
I mute myself. That's presentation. Let me see if I can share it now.
Yep.
The sharing. Can you see? Can you see?
No.
Interesting. Okay, sharing. Yeah.
Yeah.
Excellent.
That's
Okay.
perfect.
Fantastic. So that's right. Okay. I'm sorry I couldn't get the formation, but I will do it for next time.
No problems. That's absolutely fine.
Yeah.
You can go to full screen, Leila, on your presentation.
Oh, sure.
Yeah.
Okay. So it's a 2-month-old baby, X 25 weeks, 900-gram baby, currently 2.2 kilogram with diagnosis of chronic lung disease. Baby start having tachypnea with feeding and oral, although oral feeding was improving. Respiratory support remained the same, no change. I just wanted to see what exactly making this baby needing the oxygen despite improvement and the feeding improvement and trying to wean oxygen slowly. So this is would be the right anterior superior.
Lovely. This is R1.
This is R1, yes.
Beautiful.
And yeah, oh, sorry. So I see a nice sliding, thick, I could maybe call it irregular pleura. more than 3 ribs, and mostly I would call this B profile.
Yep.
Next slide would be the right anterior inferior. Again, a sliding, thick pleura, irregular again, and pre-profile mostly. Okay. This is lateral superior. Again, the same picture, sliding, thick pleura, irregular, and pre-profile. I would say the same thing here. You could see more compact B profile. Same picture, lateral superior. Do I go? I'm sorry, I'm not going. I'm not changing. Yeah.
No, that's very nice. Yep.
Yeah. And this is now left side, anterior superior. Very short video. I'm sorry. Yeah.
No, that's okay. Perfect.
Again, sliding, regular and thick pleura with B profile mostly. This is anterior inferior, thick sliding pleura, compact B profile. Sorry. Lateral superior. Maybe my probe was not really in good perpendicular position, but again, you see some A lines, but mostly pre-profile, and I would call them compact again. Lateral inferior, I would say the same picture. And that's it.
Very nice. So Leila, we'll go back to your first slide.
Sure.
That's beautiful. So basically, yeah, the history, we'll just have a look at the history.
Sure.
So this is a 25-weeker who's basically about 33, 34 weeks corrected at this particular point. Really good weight. And clearly this baby has got nasal cannula needs. Now, expectation would be that if you had a baby who was completely well, who had transitioned and didn't have any clinical problems, then what I would say is that you'd expect a complete normal A profile with a completely thin, bright pleura, which was regular with sliding, parallel A lines below that, and what would be a normal lung appearance. So what are we seeing? So we'll go to the first slide. So first of all, very nice orientation. This is basically what we'd call a linear probe, which is being used transverse in R1. So it's kind of in a situation where it's placed longitudinally. My apologies, in R1. So you get multiple ribs with the intercostal kind of muscles in between, and then you get this very thick pleura. And I mean, one of the questions one of our participants has actually asked is, are the gain settings up? And I would say no. Actually, because we've taken this with a kind of a mobile, the mobile basically is giving us a reflection which makes the gain look a little bit more. But actually what this is demonstrating is a very thick, very irregular pleura. And you've got these areas that jut in. These areas that jut in that are triangular, especially when you go to the superior part of the field, these are consolidations. These are classical subpleural consolidations. Below the middle of the subpleural consolidations, you actually see some A lines. So just in the middle.
Over here.
Yeah. So just below that, Leila, just below.
Sorry,
That's perfect. Yeah, these ones. So what you've got is a dominant B profile with some lung aeration in that particular part. And naturally, we know that the anterior part of the lung is well aerated. And then you have this small area of lucency. There's a very small area of lucency that you see in the middle. Yep, there. Okay. So these are shadows of the ribs. So don't get too worried. This is not a shred sign. This is very important for you to understand that sometimes people think it's not a shred sign. First, it doesn't merge with the pleural margin, and you see similar dark shadow coming beyond the margin of the rib. So don't get too confused. That's actually well aerated lung with an A line, and the reason you're getting that is this is what is classically called a mirror image artifact of the rib. So you've got the rib which is being duplicated below it. But for me, this is, if I correlate at this particular point, I'd say those lungs look like chronic lung disease, evolving BPD. And the classical pattern with evolving BPD for babies who are supine on respiratory support, who are not being prone, is that this gets worse as you move to the lateral and posterior regions. So let's move forwards in the slide.
So this is what
And
we can.
yeah, so again, the lower region on the right side, very, very heavy pre-profile, very thick pleura with significant subpleural consolidation. So those areas of whiteness that you see that jut into the lung. So
This one.
yes, these are basically proper consolidations. There is an element of, again, just artifact there. You can see the rib again. So there's a lucency that you see. This is a mirror image artifact of the rib. But
So these are the ones you're talking about, right?
yeah.
Okay.
Just when you look behind them, so there's this dark area that you see very nicely on the left side below the rib. Yeah. And then again, if you come to the upper zone, so these are basically rib shadows. So don't feel too anxious. This is not a shred sign, but a very irregular pleura with a dominant B profile. Maybe the lower part has the occasional A line. So if you go right down to the lower part, right side, yeah.
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 Okay.
So that area there, yeah, just take your arrow slightly higher. Yeah, there. That basically you can see A lines in that particular region. So if you play it again, but you can't see any A lines in the superior part of the lung field. So again, very chronic lung. And we'll go to the next slide. What you can see is as you move kind of laterally, I mean, you see no A lines at all. And this is gravity dependent interstitial edema. There's fluid in the interlobular septa where you've got these B lines that have kind of coalesced. And in this one, you have very beautiful image. Yeah, so if we just play this again. So these B lines have coalesced into kind of columns. Yep, like this. So and these are called compact B lines. And really what they're reflecting again with that irregular pleura is basically interstitial edema with the lung that is basically chronically a little bit scarred with interstitial fluid in it.
So
now, yeah.
Would you call this also, this is pneumonia here?
I'd call it a consolidation. I'd call it a consolidation. I can't see any kind of dynamic air bronchograms. I can't see a shred sign. So I would say that there's subpleural consolidations. They're quite significant. And, you know, for babies like this, say, for example, if you had a complete whiteout and you put this baby on CPAP, say, and put the pressure up, what you might find is that you've aerated the lung a little bit more in that zone, laterally and posteriorly, to be able to recruit lung. But clearly this baby is 2.2 kilos and doesn't need the respiratory support. So often these babies will have this lung appearance for an extended period of time. And what you're really looking to do is grow these babies and grow these lungs.
Okay. So what we did for this baby, we just went up with the flow, and that seemed to be helping the baby, you know.
Amazing.
Yeah, with feeding and this kind of thing, just get kind of pressure to inflate the lungs.
So a good example again of looking at your lungs, and really what you want to recruit is lung that looks more B under recruited, and it's the ratio of air to fluid. And for those of you who attended the last talk, I took you through the last slide, which basically gives you different pathologies based on air fluid ratio. But when you look at very severe chronic lung disease, often there is a lack of aeration, in particular laterally and posteriorly. The lung, in particular, the pleura, it's thick, it's scarred. Sliding is usually present. So again, because you have sliding in all these zones, as you can see, I mean, what you've got is clearly, I would say it's unlikely to be atelectasis, complete atelectasis, where usually sliding is very poor and absent. So the lung is definitely fully expanded, but it's just a very B chronic profile. Any questions by anybody? Anybody have any questions about this?
How to different? I have a question.
Yeah.
How to differentiate between consolidation and the fluid, like fluid in the lung?
So fluid in the lungs and consolidation. So, I mean, that's, I would say that what you really don't want to do is get confused between pathology and terminology. Now, fluid in the lung, as I will describe to you in today's talk, can exist in multiple different places. It can exist in the alveoli. It can exist in the interlobular interstitial space. Fluid in the lung can also exist in the pleura. And really, depending upon where the fluid is, you will get certain typical patterns or pattern recognition kind of constellations that then point you towards that diagnosis. So consolidation, again, is a kind of fluid in the alveoli. And when you get fluid in the alveoli and less fluid in the interstitial space, what you get is this appearance of whiteness. And the reason for that is fluid, the acoustic impedance between this area and, say, ultrasound waves which are traveling between muscle, it's very high. And because of this high acoustic impedance, what is happening is you're getting very good reflection from fluid, which allows the waves to reflect back, but also will conduct waves to the deeper tissue. So really what you're doing is you're using the ultrasound properties at this particular stage to kind of get a feel of where your fluid will be distributed. Now, I think if you were to look at pleural fluid, for example, that would be in the pleura, and that would be well outside the pleural margin. The lung would be completely collapsed. So I think what I would say is that consolidation will give you these bright white appearances. You can see deep superficial consolidation, whereas fluid in the pleura, say, for example, will give you a very dark margin, because actually what it will do is it's a very poor reflector. The pleura is separated, and we know that the pleura is the main reflector when it comes to lung ultrasound imaging. So if your pleura is separated, visceral and parietal, your good reflector is gone. But more importantly, with fluid in between those two layers and skin outside, the acoustic impedance is even higher. And what you get is no air penetrating into the deeper tissue, which gives you a completely black appearance. So again, what I would say is we probably get a little bit more clarity after I go through today's talk. Any other questions?
Thank you.
Stop sharing now.
Yes, please. That's so kind of you. I'm really grateful, Leila. Fantastic.
Can I try one more time to share?
Yeah,
Only
sure.
for a second.
Yeah. I have no problems. Go for it. For us, this is a peer review session. My intention is to make this as interactive as possible. Our peer review sessions give us a lot more in terms of our learning. Well done. I can see your screen. That's beautiful, Kirti.
Okay. But I think there are lots of things on my screen, no? Or is
No,
it clear?
it's okay. I can see you probably want to go to the first slide at the top. Yeah. Beautiful. Now go to slideshow. Excellent.
Okay.
Lovely.
Okay,
Well done.
so this is a 34-week or 6 days, 2 kilo tachypnic since birth on high flow of 6 liters with oxygen requirement of about 21%. And I did the scan at 6 hours of life. This was the chest X-ray. It looks more ground glass appearance, but we were thinking more of TTN or mild RDS.
Okay. Lovely. Yep.
It's not moving. Okay. So I used a linear probe with 9 hertz of frequency. This was the maximum that probe had at musculoskeletal preset. I adjusted depth and gain, but I didn't have an option to make any adjustments to focus or harmonics.
Yeah. Don't worry about harmonics. Just completely forget about it. It doesn't alter. It may actually make, if you apply harmonics, it might make your image much worse. I think for focus, what I'd say is that, are you using a preset kind of, is this a preset for musculoskeletal?
Yeah, because it only gives options for thyroid, musculoskeletal.
So the problem with using a preset is it will not let you change the focus, because the preset is made to look at the musculoskeletal. If a better way to do it is to select your general probe, general settings, adjust your frequency to 9, and then you should be able to adjust your focus. But as discussed, this coming Tuesday, we're going to have a bottom call to have a look at your machine. So yeah.
Okay, I had to take these images on the machine and then on the phone because I couldn't transfer.
No problems.
So this was right anterior.
Yep.
And I think it's more of clear lung sliding with some B lines and comet tails maybe here, and then clearer A lines. So
just play it. So what I'd say is that you've got beautiful lung sliding. So first of all, if I comment on by order, you've got 3 ribs with an intercostal space. You've got a nice batwing sign between the 3 ribs. For those of you who don't know what it's like, I will describe it. Can I just say that I can see a lot of comet tails. I can't actually see any good beelines.
Okay.
I can't see a beeline that actually extends all the way through, and a beeline should extend the length of your screen right to the bottom. I'd also say your depth is, it's 2. You really need in a term baby to get a depth of a 4.5 to 5. So what is happening is that your deeper lung tissue, you're losing half the deeper lung tissue.
Okay.
Okay. But again, if you look at the pleural margin, it's relatively sharp. It's relatively sharp. Again, there are no subpleural consolidations here. What you see is comet tails. Can you see
Okay.
those areas there? They are
Yeah,
comet
yes,
tails.
yes.
Yeah,
Okay.
they're comet tails. They're basically vertical pleural artifacts that arise from the pleura. And the reason I'm saying they're comet tails is, can you see how they're horizontal? So, so normally a beeline is very sharp vertical, whereas here you've
Okay.
got a lot of parallel lines which are in a, it's kind of like a brick upon brick. So that's the classical appearance of a comet tail. These aren't subpleural consolidations. These are comet tails.
Okay.
Very nice image. Your gain settings are good. Your image is very sharp. Your image is very sharp. Again, you can adjust that, but I would say this is a very nice image. So if I interpret it, you've got good kind of gain settings. You've got pleura that's regular. You've got lots of comet tails, no B lines, and you've basically got A lines through and through.
Okay.
Yeah.
Okay.
This for me is this is an A profile. This is what I would see normally in this baby at this age. Let's go to your next image.
This was right lateral because this baby was lying supine.
Yeah.
This was right posterior.
Yeah.
I'm not able to play this.
Not a problem. It's again, it's a really good example of what is it's playing now. I mean, this is barn door completely normal lung. You've got pleura, pleural sliding. You've basically got what looks like parallel A lines, so horizontal reverberation artifact. I can't see anything in terms of comet tails in the lower image. My only comments are you're really looking at the superficial part of the lung. And the problem when you go to the right lateral is you're virtually not seeing much because the majority of your lung field is being taken up by skin, soft tissue, and ribs. And for that reason, your A lines are becoming obscured, and it really looks like you might have a B profile. It's not. These are comet tails, which is superficial, and because your depth is very low, you're not really getting the A lines. So what you need to do is increase your depth, and you really need a depth of 4 to 4.5 centimeters. But for me, a regular pleural line, no subpleural consolidations, parallel A lines. I mean, clinically, I'd say that the right anterior and the right posterior, they're normal. I can't say that you have any B lines in these zones. And my gut feeling is the right lateral, if we'd had good depth markings, they would have been normal as well. Now, what is very important for guys who are looking at the right posterior zone, folks, if you could not see sliding in that zone, and you can see sliding. So if you press that again, you can just see this sliding that's there with the A lines. But if you see a completely still pleural line with this kind of pattern, you really need to think about a pneumothorax. Now, what I would say to you is that for babies who are supine, air rises anteriorly, laterally. It doesn't go posteriorly. So first of all, if I was confused in my mind that there was no sliding, and some of you might be confused and say, well, is there sliding? Is there not sliding? What you can do, which is sometimes not really nice, is basically try and stimulate the baby to cry a little bit. And when the baby cries, actually the sliding becomes more apparent. Be gentle, a little bit of a tickle of the foot, trying to elicit the Babinski, and just upsets the baby enough to kind of breathe harder, breathe a little bit deeper. And that actually makes your sliding more prominent. So, but for me, this is normal lung ultrasound appearance. Now, what I'm going to highlight to all of you, I mean, we've had about kind of an hour of teaching. We've seen 3 really good cases. But I want to emphasize to you how important clinical correlation is in this situation. But more importantly, you're all using different probes, different settings. You're all using slightly different machines, which give you slightly different kind of pictures. But actually, in terms of being able to make an interpretation, if you clinically correlate, you can very much come to the diagnosis of what you're seeing. And what happens is with time, you get used to your machines, and you just have to be a little bit careful with that, because if you start using a different machine, and that's the beauty of having these peer review sessions, is you can see different machines, different pictures, and what they actually look like, to be able to compare your machines but your images. And a really good example again over here is the fact that if you had more depth, you may well have been able to see B lines that might not be seen at this particular point because you're missing out on some of the lateral regions. So again, what I'd say is try to get your depth to 4 centimeters. And very, very important from your perspective that if you're using, because you're selecting MSK superficial, vascular will usually auto default if you're using ultrasound to a depth of about 1 centimeter, and MSK muscle skin will default to a depth of 2. So try increasing the depth. If you feel that's not working in a preset setting, then what you can do is just choose your general setting, set your frequency to 9, which would be sufficient for a term baby, adjust your depth, and then it's literally trying to get your focus to the prudal line.
Okay.
Any questions from anybody before we move on to the presentation? Okay, so Subhash has asked us a question about the ideal gain setting to be kept. Now, what I would say is it will change for every machine, but in general, what you want to see is you want to see the pleura being relatively bone bright, and if you have auto gain, then get to your depth and press auto gain. But if not, what you really want to be able to do is accurately differentiate normal lung with A lines. So if you can see parallel A lines, then I would say your gain settings are appropriate. A line attenuation, again, can sometimes be a little bit confusing, and I'll explain that in the talk today. But you might just have to turn your gain settings up if you're slightly confused about whether you can see distal A lines which are getting attenuated. I'd say the gain settings in this particular machine are relatively high, so you might just want to reduce them a little bit. I think the gain settings, when you saw Layla's images, were perfect. They're really good. And again, I'd say the gain settings that you saw on Mayank's slides were also very good. Too much gain will basically make all your lung very bright and granular. And I think just here, the gain settings are on the higher side, which is why you see everything in a very granular kind of a fashion. So you might just want to turn your gain down a little bit. Auto gain on your machine is the best way to try and get your ideal gain set in. And you can get it set up on every machine.
Okay.
So any other questions? One last question before we start. Kirti, are you able to stop sharing? That's so kind. Thank you.
Just one thing I wanted to ask. I had taken transdiaphragmatic also, but they weren't very clear. This was a transfer. This was right transdiaphragmatic, but I can't see the liver in this.
So my gut feeling is because are you doing this vertically or are you doing this horizontally with the probe marker to the right?
Horizontal.
Okay, so really what you are is you're on one side of the chest directing. This is the entire lung on the right side. You've got a very nice pleural margin with a classical A profile, multiple A lines of kind of normal echogenicity parallel to each other. But you don't see the liver because actually, I think for one thing, I mean, your depth is there, but I think you're just completely to the right of the chest. Are you completely to the right of the chest?
I aligned it along the subcostal margin.
Yeah, that's the thing.
When you do it for the liver scan.
Yeah. So what you need to do is you need to use cardiac situs view horizontally with the probe marker to the right. And what you'd be doing is angulating the probe under the rib margin using the liver as the shadow. And a really good example is your image on the left. That's perfect. So if you wanted to see a pleural effusion, you'd see it just in between the liver and the lung.
This here is here, is it?
Yeah.
Okay.
And I mean, what I'd say is, again, you've got a complete A profile, maybe on that little zone near the liver, just below. There's a very hyperechoic area, just a little bit of consolidation there. But
Here
I
it
think,
is.
yes, yeah.
Okay.
But rest of it looks like a classical A profile. Because your gain settings are so high, you're
Mm,
getting very granular images. You might just want to try and reduce your gain settings a little bit.
okay. Thank you.
No problems. So I am going to share my screen, and I hope I'm able to share. So can you see my screen?
Yes.
And can
Yes.
you see the slideshow?
Yeah, it's perfectly
Yeah.
visible and audible.
Yes.
Excellent. So what we're going to talk a little bit about is neonatal ultrasound physics, and in particular, the concept of artifact in neonatal ultrasound. So first of all, just a little bit of a recap from the last talk from people who kind of weren't there. So ultrasound waves typically refer to a frequency over 20,000, well beyond our hearing range. But an ultrasound wave is generated through an ultrasound machine. And what is the ultrasound machine? So the ultrasound machine is connected to a cable, electricity that comes into the ultrasound machine. This electricity basically is made to move through a piezoelectric crystal. And when it moves through a piezoelectric crystal, it basically generates waves because the elements of the crystal vibrate. Now, these ultrasound waves they will hit tissue or hit whatever's in front of them. And based on the property of whatever they're going through, will go through a variety of different effects. So some of them will come back to you, they'll be reflected. And the reflection, I would say, is the foremost mechanism by which we're able to actually see images. Reflection back to the ultrasound probe is then taken back into the machine, and an interpretation of that reflection is then put on to generate what we call is a two-dimensional B-mode image. Now, some of the waves will reflect back, but then some will go into the tissue, they'll get absorbed. And if they get absorbed, the strength of the signal will keep going down as you go into tissue. And as the strength of the tissue goes down, so I'm just going to use my marker to explain things. So this is ultrasound waves going through. They're kind of hitting tissue, and then they're being reflected back, being interpreted by the ultrasound machine, creating an image. But some of these waves will go into the tissue, they'll get absorbed, and that will cause attenuation. So because the tissue absorbs them. But the other thing is there will be reflection between these layers itself. And when there's reflection between these layers, some of the signals going back will be less strong than the reflected signals. Some of the signals will then get transmitted to deeper tissue. They'll get reflected back and they'll be even weaker. So often what you find is that surfaces which have good reflective margins tend to produce bright hyperechoic images. And the property that determines a good reflector is called acoustic impedance. And if you have a high difference of acoustic impedance between one tissue and what's below it will basically be a high reflector and a pretty bright. But if you have an area of uniform tissue, say fluid, where there is no difference in acoustic, let's say there's fluid in here, then these waves will, obviously some will reflect back from the pleura, but some will just go in and they'll go through that and they won't reflect back at all. Some of them will get damped. Now, if they don't reflect back, those areas will basically be reflected as dark. So pleural fluid, say, for example. But more importantly, if you've got air in this interface and you've got skin here, then actually you're in big trouble because air doesn't let anything pass through it. And if that is the case, you're not really going to get anything. You just get nothing, a nothing kind of an image. But more importantly, how do we help ourselves? We put gel in between to remove that air interface so that we can actually see and define what we call is human anatomy. Now, this is a very, very important concept. And that normally when you look at ultrasound of the brain, or you look
Dr.
at,
Alok, your
yeah,
screen is showing presenter's view. Can you change the view to slideshow?
okay, my apologies. Sorry about that. I'm just going to stop share. just gonna share screen again. Now you should just see the screen. Can you just see the screen?
Yes, now it's
Excellent. Yeah.
okay.
My apologies about that. Sorry. So what I'd say is that when you look at ultrasound of the heart, and in particular of the brain, really what we're looking at is the interaction of these ultrasound waves and the tissue beneath, but in a way that structurally defines the anatomy of what you're seeing. So, I mean, let's assume this is the left ventricular kind of cavity at this particular point. So the heart comes through as an image like this on B mode. And really, the most important kind of image is generated by reflection from solid tissue, which you see, which is basically the interface between musculoskeletal and heart tissue, so high acoustic impedance, which creates a bright reflecting surface. But as waves go in, they go into a fluid-filled cavity. And this fluid-filled cavity doesn't have any difference between impedance. The fluid has got just one density. So actually, nothing's being reflected back very well. And for that reason, you're getting a very dark view. But then they hit the posterior wall, which again is a very good reflecting surface because there's a difference between fluid and the interface here. So these waves being reflected back and being reflected back in a way that kind of goes into the probe defines the anatomy. Now, classically, waves that get reflected back at 90 degrees produce the brightest images. So you can see that if you get reflected back at 90 degrees, you get a very bright image here, which is kind of the outer wall of the LV. On the other hand, this margin over here is quite irregular, the inner cavity of the left ventricle. So when waves go here, they undergo what is called non-specular or scattering kind of reflections, which kind of give you a slightly less intense image as compared to the outer wall of the left ventricle. Similarly, the papillary muscles being a little bit more in the way can reflect back a little bit better. So they're a little bit brighter. But I think what I'm trying to highlight to you here is there are a variety of different things are happening at the level of the tissue, which is creating this image. Obviously, as waves go in, they become weaker. You have attenuation. Some get absorbed by the tissue. And because they're getting absorbed, you're getting this dark image over here because the waves that are going back are weaker. But more importantly, as you see, brighter tissue at the top, slightly darker tissue at the bottom. And then you have high acoustic impedance at the distal end, where the pericardium comes into view. So again, sound waves that are able to penetrate, hit back, and because there's a high difference in density between this tissue and the pericardial sac, you get a very bright image. Now, the reason I'm showing you this slide is because in your mind, you might be thinking, when I look at lung will actually be anatomy. But the fact is, what we're looking at when we look at lung is not just anatomy of the skin, muscle, and the ribs, but actually what you see is artifact. Now, we're going to talk about artifact. And there's a huge amount of artifact that's generated in ultrasound. But more importantly, one of the important things is as machines have become better, the guys amongst us who developed the machines wanted to reduce artifact. So when you try to get good images of the heart or the organs, really what they're trying to do is make this more uniform, make this equidistant, improve the interaction of these sound waves in multiple different ways. So they're reducing artifact. And the challenge with that now is that if you have new machines which reduce your artifact, they actually make A and B lines much less visible, which then makes interpretation more difficult. So over a period of time, machines that were used, which basically used B mode with a lot of artifact, have moved to machines with less artifact. And for that reason, what you'll find is that your images aren't anywhere near like what the images of the old machines like the high-techs were long back, where you'd see very nice barcode signs, you'd see very nice seashore signs, you'd see very sharp margins. And that is because the artifact generated was just much more as compared to new machines. As a first, let's define what artifact is. And I would say to you that artifact basically is an ultrasound image that's generated from something that does not exist. So normally, if you're looking at the brain, sound waves are bouncing off the brain and they're giving you the sulcal gyral appearance with the structures that are deeper down. But when you're looking at an artifact, what is happening is that you're getting an image of something that doesn't really exist. Now, that could be a size, shape, or location. And when I talk about size, what I'd say is that the B lines that you see are basically fluid in the interlobular septa. Now, that's not an anatomical structure. That's fluid within the interstitial space of the lung. So actually, what you're looking at is not anatomy. You're looking at very tiny bubbles interacting with each other, reflecting the sound waves, which are then creating reverberation. And that reverberation, that movement of sound, creates or reflects sound back to the probe, which then interprets that with a pattern. And it is that pattern that you basically see and help to define normal from abnormal lung. So clearly, what you're seeing outside this window is these lights, which are actually lights within the actual room. So really, that is what artifact really represents. The problem is the machine basically doesn't know that. Now, when you look at what the machine knows, it basically thinks it's putting an ultrasound wave through a tissue that's uniform, which will reflect back 100% so that it can give you what is a crystal clear image of whatever it's trying to get an imprint on. In real essence, if you look at the lung, there's a huge amount of heterogeneity. And that comes from the fact that you have skin, you have ribs, you have intercostal muscle, you have tissue. I mean, if you're as obese as I am, you have a lot of fat. And in particular, I think what I would say is that you then transition into lung tissue, which is a mix of alveoli, interstitial space, fluid, and then there is an outer covering of pleura. And all of these interact to give you an image, which really is not anatomically correct after you head below the level of the ribs. Now, why is ultrasound artifact important? Now, traditionally, most people would try to minimize artifact because artifact is not really real. It's just what I would say is something that you see which doesn't actually have kind of an anatomical correlate behind it. So really what you might be looking at is what I would call as a mirage of something that doesn't exist. Now, obviously, if you do that in the case of the liver or the brain, the risk is what you will interpret is maybe calcification, where you see a blood vessel because your gain settings are very high. So clearly you will form an image in your mind that actually this looks really bright. We're kind of in a situation where it looks bone bright, but actually your gain settings are massively high. Or your probe is attached in a way that it's looking at a blood vessel. So you will basically make a faulty diagnosis. Now, the risk with that is you might think, well, actually, this kid has either very bright sulcal appearance. Does he have meningitis? Well, should I treat him with antibiotics and do a lumbar puncture? And that might just be a reflection of the fact that you've got artifact because of high gain settings. So traditionally, what we've tried to do is we've tried to improve our ability to interpret things by optimizing our image quality. But in the lung, what we're doing is we're actually using artifact to pattern recognize and create patterns that we can then differentiate to help us recognize what normal lung is and what abnormal lung is. But in particular, once we know what is normal and abnormal, we're then using those patterns in different areas of the lungs to then give us an overall impression of what we think is happening in the lung in each part, R1, R2, R3, R4, R5, R6, and similarly on the left, to give us a flavor of what the lung appearance like is at that point of time in the context of what is happening clinically to that baby. And for some situations, really, you will need to do more than one lung ultrasound. You'll need to do serial lung ultrasound to interpret this artifact, to give you an idea of exactly what is happening. But what you can classically see in this image, I'm just gonna get my pointer, is very classically what is called the lung point. Now, the reason we're calling this lung point is because actually this is a pneumothorax. The reason it's a pneumothorax is you've got a very classical B profile, very irregular pleura. Again, can you see the difference between pleura that's sharp and regular versus pleura that's completely irregular? And then you've got these small consolidations here that you can see, which if you look at the margin, that's about 1 centimeter. So that's more than 1 centimeter worth of subpleural consolidation with a complete classification. There are no A lines here. There's completely, there are no fused B lines. This is just white. And this is actually what we call AIS. But then you have the sharp demarcation point. And if I were to say to you that there's no pleural sliding and you have A lines in this region, actually this would reflect a pneumothorax. And if you did a mode and saw barcode sign, you'd be able to see a pneumothorax. But the reason I'm showing you this is rib This is acoustic shadow, which gives you that dark area. In between, you have basically muscle. And this is the pleural line. And I would say that that is about as much as the anatomy as you're going to see from an ultrasound, because the rest of what you're seeing below that is complete artifact, both here and here. And I will explain exactly how this is generated.
I have a doubt.
Yeah,
Can you go back to the slide?
yeah, sure.
Yeah. So, it might, if there's no video as such, then it might be very difficult to differentiate from double lung point, because it's practically the similar, because there would be aerated lung in the upper zone and um, uh, there would be B line, B profile in the lower.
Okay, so just my question to you is, why would you be watching a still image? So whenever you do your lung ultrasound, you're always going to be using loops. Lung
Yes, yes.
ultrasound,
I'm
yeah,
just asking about this particular image. By
yeah.
just looking at this image, we cannot make a
No,
judgment if it is.
Yep.
Uh,
I completely agree. I completely agree. I think what I'm trying to give you is an analogy of why they're using the terminology lung point, because actually, if this was a loop, you would not see sliding. But
okay.
there's a difference between the lung point and the double lung point. And for all practical purposes, this is a pneumothorax on a still image.
Hmm.
On a moving image, you would not see pleural sliding.
Okay.
Okay. Now, just a few things about how we generate artifact, because unless you understand this, you're not going to understand what B-line progression is like, why we see a kind of a batwing appearance to the lung, and why that's so important. Now, for all practical purposes, there are hundreds of kinds of artifact, but for the purpose of lung ultrasound, I want you to understand 5 types of artifact that we're going to talk about today. And this will cover the majority of everything that you see on lung ultrasound. And what we're going to do is try and make this as clear as possible. So the first thing is what we call is shadow artifact. It's a simple thing, so I've taken it first. And if you look at shadow artifact, what a shadow artifact basically reflects from your perspective is that your ultrasound image is coming from here. This is your probe. This is a sector probe. So your ultrasound waves are going in this direction. Now, clearly, as they go in, they hit and pass through tissue, but you've got bone over here. Now, what we know is bone has the kind of interface between tissue and bone would have a very, very high acoustic impedance. So bone would be a massive reflector. It's probably going to reflect virtually 100% of the waves back with very little penetration under the distal tissue. So classically, what you've got is you've got these shadows over here, which are basically rib shadows. And really what you're trying to do when you're doing longitudinal scanning is you're trying to get a good zone of imaging to be able to get at least 3 ribs, 2 intercostal spaces to be able to define one lung zone. You will have these areas of blackout where you're not going to be able to see things. So you have to move your probe up and down to try and optimize and get that image as good as possible. I think the problem here is we can only see one really good intercostal space. But the pleura, again, because of the difference between tissue and pleura being relatively straight, will cause a lot of reflection. And the reflection will be at 90 degrees, which is why you'll have a very bright appearance to pleura. But more important, that reflection, because you breathe and the pleura slides, is visible. And that basically is visible as what we call as lung sliding. And for lung to be normal, you always have to have pleural sliding. So if you look at shadowing and the ultrasound machine and the principle of the fact that it is because there is virtually complete reflection of the ultrasound waves back so that they can't actually penetrate into distal tissue, you will see dark areas behind the ribs. But more importantly, if you get air in the pleura, now this is very important. Air basically is a massively, massively strong reflector. Now, if air comes in between the pleura will disappear completely, because when waves come through, they will hit the first pleural margin, not be able to penetrate through the visceral pleura, and actually you will get absolutely nothing visible in terms of the pleural margin very well. But more importantly, because the pleura is separated, the pleura will appear still. And what you'll get is that superficial layer of pleura, which is visible, distal layer not visible. So because you can't see the distal layer of pleura because there's air in and it's reflected back, you get a blind pleural margin that doesn't move. So Zaruddin, you have a question? Go for it.
Yes, thank you. Thank you very much. I just really wanted, while we are discussing this very, very important foundation for the lung ultrasound, is I wanted to clarify and organize the thoughts in my brain.
Yeah.
Stereotypically, the artifact is something that is not useful in ultrasound, so we discard it and look at the picture beyond the artifacts. And also, I always consider it a skill at some point that you identify the artifact that you will discard and not consider as relevant whenever you are doing any ultrasound scanning. My point is about the terminology. When we say artifact and we put all these shadowing and so forth under the umbrella of artifact, I just get a little bit confused, because I think, as you mentioned in the previous presentation the other day on Saturday and today, obviously, it is the construction of the picture that is generated that will give us a view of what the lung is looking like, and it's applicable also for the heart as well, or any other organ. So it is the construction that is being produced by the ultrasound waves. When I'm just having my point is that to call these artifacts, they are useful artifacts, of course, because they are giving us the ultimate picture of the lung ultrasound that we will interpret. But I'm just having an issue with calling it artifacts, because I'm under the impression that artifacts are usually and always been something that we have to ignore on an ultrasound image. Correct me if I'm wrong. Thank you.
It's a beautiful question, and I have been asked this so many times. And really what I'm trying to highlight is that there's certain aspects of ultrasound which basically duplicate the structure of the organ without artifact. And a good example is the myocardium. So the exact structure, the bright outer layer, the bright inner layer, the kind of interspersed tissue layer, they're actually anatomical correlates. So they're not actual artifacts. But in lung, what is happening is, and as I go forward, it'll become a little bit more clear, is that what we're seeing here, this is not tissue. This is not alveoli. This is not fluid. This is actually a reflection of this pleural line. And what has happened is that ultrasound waves have interacted with this pleural line. The majority of them have reflected back, maybe 50%. Then because you've got a pneumothorax, this pleural line, the outer margin, has reflected back and given you this bright line. But the inner margin, actually, because there's air there, has separated. And because it's separate, you do not have the sliding of the parietal and the visceral pleura, which is why in a pneumothorax, you've got absent sliding. Now, while this is an anatomical correlate, these lines that you see here, they are not actually anything related to the lung tissue. They're just attenuated ultrasound waves that are getting weaker and weaker and weaker. And the reason you can see them is because this area of the lung has got air here that is not letting enough sound waves penetrate. But more importantly, air has caused the lung to basically collapse. Now, because this lung has completely collapsed down, you're not going to get any artifact that you would normally see in between the lung. So if you get my analogy here, what you're really seeing here is nothing to do with the tissue. It's really reflections of the pleura. Similarly, when you have lung that's expanded, again, we would expect, well, if this is liver, actually liver tissue here, the granularity that you see is causing reflections back. They're actually giving you the tissue, exact tissue appearance. But here, the reason you're seeing this is because there are extremely small bubbles in the interstitial space of the lung, and they're interacting with the lung ultrasound to give you reflections back. Now, in essence, they're not actually reflecting the lung anatomy, the alveolar anatomy, nor are they reflecting the alveolar tissue. And hence the kind of concept that this is actually, in a way, a kind of an artifact, because you can't actually see the bubbles, but they're giving you this image. So the analogy I'd give you is that we're using a kind of a pattern, a puzzle to kind of say, well, this is the appearance you have. And because you have this appearance, this is the kind of pattern I would see with a baby who's got transient tachypnea versus a baby who's got pneumothorax. Does that help?
Of course, thank you. Yes, thank you very much. Yeah.
So just again, what I'd say to you is that the reason you're kind of getting this shadow at the moment is because you can't get any ultrasound waves to penetrate bone. Now, the classical bat wing appearance, so that's the wing. And actually, this is the bat's head. And that classical appearance that you see is pretty much because you've got what is called shadowing. So if you look at the bat wing sign, you've got the rib over there. So that's the wing of the bat. That's the kind of head of the bat in between. And you've got these rib shadows over here. Now, classically, when you see a bat wing appearance with a pleura that moves, this is classically called a bat wing sign. Now, as ultrasound waves go in, we know that they lose energy, they get absorbed. So you get this attenuation. So this pleural line and its reflections gradually get attenuated. But why do we, so we know that the pleura is a very high reflector, so it reflects back ultrasound. So why do we get A lines? And I'll come to that. But what happens is that in some cases of shadowing, so you've got a rib shadow over here, you really want to get in between the ribs to be able to get the interstitial area of the lung, to be able to generate what is a pattern. So if you keep your probe over a rib, you're not going to see very much. And that's why I would say that for some cases, like if you want to look for a consolidation in a particular area, and you just do longitudinal scanning, you might miss them. This is a very classical, I would say, transverse scan. So you can see a very nice rib shadow that's coming in with it, the pleural line, and you can see these B lines over here. But this is classically what we call a bat wing sign. And these are classically vertical reverberation artifacts, which are called B lines. So these are the two artifacts that we'll be talking a lot about. Now, how is shadow artifact generated? So just to give you an idea. So sound waves basically hit into the lung. So you get this scent wave, which interacts with the superficial tissue. It hits the ribs, majority gets reflected back, and you get these areas of what we call our complete opacification behind the ribs. And that is an acoustic shadow. So really what you're seeing when you see the bat wing shadow is this area of tissue in between with the ribs like this and a pleural line. And this is classically what we call the bat wing appearance. And as I've said, this is exactly what it looks like. It's going back very quickly. So this appearance, this is normal lung. If you see sliding here, you see this pattern with parallel A lines, less than 3 B lines per interstitial space. And this is what I would call is a normal lung appearance. Can you see how the focus, this is where the focus is, and what you really want to do is get your focus to this line over here. But very importantly, from your perspective, again, the depth here is very high. So you really don't have enough tissue to see. What you really need to have is a depth of about at least 4 to 5 centimeters in a term baby and about 4 centimeters in a preterm baby. Let's quickly gone through why we get the bat wing kind of shadow. Now, a very important aspect of what's happening to the waves in between. Now, 90% of the waves get reflected back from the ribs, but for the sound waves that are able to penetrate in between tissue, these sound waves reflect back. And classically, from your perspective, the pleura will give you the maximum reflection, but the alveoli, which are organized in between, tend to reflect back as well. And when the alveoli reflect back, you have what is areas behind the ribs, which basically show gradual attenuation of this pleural line. So the pleural line travels in because there's no tissue interfering with it. And that's what gives you what we call is horizontal reverberation artifacts. On the other hand, if you have increasing fluid, the fluid accumulates in these spaces, which are the interlobular spaces. And these interlobular spaces create what is called a vertebral reverberation artifact, which is classically called a B line. We'll show you some more videos of how that's generated. So classical bat wing appearance. Now, what is reverberation artifact? So reverberation artifact is what I've just described. So you have a sector probe. And this is the pleura, the pleural margin. So you've got waves that are coming in from a sector probe. And as these waves are going in, they cause and hit the pleura. Some reflect back, some go in. Now, as they go in, if you don't have any interstitial fluid in the interlobular spaces, what they will do is they'll interact with lung tissue and they will reflect back. They'll go further in, they'll interact with deeper tissue. Now, as they get deeper, they get absorbed. Now, because they get absorbed, what happens is you can see that the margin becomes less intense. So because of the reflection of sound waves with the tissue and the pleural margin, what you get is horizontal reverberation artifacts, where there's a kind of a shaking of these sound waves, which is then interpreted by the machine as these parallel lines. And this is what we call A lines. So what is A lines? So classically, the ultrasound sending a scent wave. The pleural margin basically reflects the majority back, but then some waves are going to go inside. And if you don't have interstitial fluid, so very little interstitial fluid, then it's going to interact with lung tissue in a way that the waves will reflect between these two areas of lung tissue. And the pleura, while being bright, will then cast shadows, which we call horizontal reverberation artifacts that you can see over here. So in essence, what's happening is the tissue is kind of reverberating these sound waves back, but in a reflection of the pleural line, which is gradually getting attenuated. And this is exactly how it looks. So the probe coming through, the maximum interaction at the pleural line, but then these waves going in, interacting with lung tissue and reflecting back and getting stuck here, reflecting back and getting stuck here, reflecting back and getting stuck here. So kind of bouncing off each other, kind of trapped is the word I would use. As you go deeper, naturally the signal of what comes back to this ultrasound probe becomes weaker, and you get what we call is attenuation, which gives you this kind of diminishing A-line appearance. Now, for a normal lung, if you can demonstrate the two ribs with the rib shadows, pleura that looks bright, that moves and slides, and gives you this appearance without any appearance of B lines, that's normal. For babies in the first 3 days, as we discussed, the majority of them will aerate very quickly within a few hours, about 4 hours. And really what you'll often see is less than 3, maybe a maximum of 1 to 2 B lines. Usually, I'd say by 24 hours, the majority of the lung is aerated. What you basically see is this kind of A-line appearance. Now, how are B lines generated? So B lines are generated by a concept that's called the ring down artifact. And what they basically mean is that we have lung tissue that's organized, but we've got these areas between lung tissue that are called the interstitial space. Now, these spaces are very important when babies are born, because clearly for babies who have lung fluid, we know that with their first cry, they'll expel about 30 mils per kilo of fluid just by crying. But what has happened before the baby is born is that maternal labor has caused the baby's pituitary gland to secrete ACTH and ADH. And both these hormones are responsible in a very big way for these interstitial spaces to become active. So because of the activation of certain channels in these spaces, which are sodium-potassium channels, which get activated, fluid gets absorbed in these interstitial spaces. And really, as the baby cries, what happens is, you aerate the lung, and really what you're left with is lung tissue without this interstitial fluid. So because you don't have this interstitial fluid, you cannot have an interaction of sound waves in a vertical manner, which is why for babies who have made full transition and have a normal appearance, you just get this horizontal A-line appearance. But for babies who have fluid, unfortunately, what happens is you've got these interstitial spaces which are full of fluid. And how is that fluid arranged? It's arranged in the form of small bubbles, which are called tetrahedrons. Now, when sound wave enters this area, it gets stuck. And it gets stuck within these tetrahedrons and gets trapped and reflected within these tetrahedrons. Now, this is not much fluid, but you can imagine that if the fluid becomes more and more and more, and the alveolar tissue also gets involved, then you basically get a cycle of trapped sound waves with a very high reflectivity that then go back to the machine. And that basically reflects your continuum of B line to B profile. So a good example is the ultrasound wave going into the lung. You've got interstitial fluid arranged as these tetrahedrons. They reflect the sound waves back, but not only do the sound waves go back vertically, they actually get trapped in between. They go all over the place. And really what you get is this kind of reflectivity, which creates what is a vertical reverberation artifact. Because of the trapped sound waves, you get vertical reverberations, and these vertical reverberations create a vertical line, which is what we call a B line. In adults, and as described by Daniel Lichtenstein, they also call the ring down artifact. I want you to forget the ring down artifact and just remember them as B lines. So how are B lines generated? So again, you can see alveolar tissue here. So let's assume this is a baby who's just been born, who's still got wet lungs. So you've got skin, you've got rib spaces, you've got this muscle, you've then got the pleural line. And in the pleural line, you've got alveolar tissue, but you've got the interstitium, which is really full of fluid. So not only is the ultrasound wave going to interact with the pleura and kind of create parallel A lines, it's also going to interact with the interstitial fluid. And there's going to be an element of vertical reverberation artifacts, which are called B lines. And how are they generated? So clearly you have sound waves that come in, reflect, they reflect back from the pleura, but they also interact with these interstitial spaces. And really what you get is these trapped kind of ultrasound waves, which cause reverberation and are interpreted by the probe as a kind of a shaking, which we call a vertical reverberation artifact. Now, if you were to see them in ultrasound, they would basically look like vertical lines, and these vertical lines are called B lines. Now, the more the interstitial edema and the worse it gets, the bigger these B lines will get. And eventually, if your alveoli get completely filled with fluid, these B lines will completely merge because you've just got fluid. And because of this, what you then get is a complete bright appearance, which we call Coalesce B lines. If it's so bad that you can't differentiate the B lines at all, then you get what is called alveolar interstitial syndrome. And if it's so bad that you can see that in every zone of the lung, R1, R2, R3, L1, L2, L3, then that basically reflects white lung. But classically, this is what B lines look like. Now, this is really, really important. You must not get confused with this. B lines are different from comet tails. And if you remember, what I said to you about B lines is they're vertical kind of artifacts. Whereas comet tails are basically, they're horizontal artifacts which don't extend all the way down distal to the deep lung margin. In fact, the pathogenesis, the physiology of ultrasound generation with comet tails is very different. Now, having 1 or 2 comet tails or 3 comet tails doesn't give you a B profile. This is really important. What you really need for B profile is proper B lines. And if you have more than 3 B lines per intercostal space, as you can see over here, what you're really talking about is an early B profile. Now that may be with lung sliding, but if you have severe RDS, say for example, with lung consolidations, then the lung sliding becomes less. So clearly B lines are vertical reverberation artifacts. Now, this kind of concept that you read, old books used to say B lines completely obliterate A lines. And I just want to tell you that's not correct. It's not always the case. And the reason it's not always the case is because the pleura and the interaction and the amount of fluid, so the air fluid ratio determines whether you will see A lines with B lines, whether you will see just B lines, thin B lines, whether you will see more than 3 B lines, whether you will see B lines that are fused together, which are called compact B lines, whether those compact B lines will then completely obscure everything and you see AIS. So it's the air fluid ratio. And as the air fluid ratio approaches 90%, you really start seeing what is dense B profiles, AIS kind of clinical picture. If it's in every zone, then really what you're talking about is technically white lung. So again, these are just examples of different kinds of B lines. So what you can see is these are what are classically called Coalesce B lines. So what has happened is you just have really bad interstitial edema. So the number of tetrahedrons in each interstitial space is 1,000 times more than it would be with a single B line. So because there's so many ultrasound waves trapped and reflecting back, you have a column instead of a thin line. of tetrahedrons. And that column of tetrahedrons basically eventually will fuse and produce what is called a coalesce B line. But when these coalesce B lines fuse together and they form big rigid columns, then what you have is what we call as compact B lines. And what it reflects is basically increasing interstitial edema, and we'll define exactly what that is. But then we have the comet tail artifact, and the comet tail artifact has a slightly different kind of pathology, pathophysiology generation. And can you see how horizontal these lines are? So they fade, they don't extend to the distal part of the lung, and they are not B lines, and they are not a reflection of, I would say, severe interstitial edema. And it's really important to know that, because comet tail signs can be seen in a number of conditions. They always originate from the pleural line and they gradually fade. But can you see how the horizontal lines kind of merge together? And again, what they are reflecting is similar kind of a tetrahedron model, other than the fact that these tetrahedrons are arranged one on top of the other, and the sound waves are basically stuck between them. So the ultrasound waves are stuck between them as they come back. I'm taking this into a lot of detail, and the reason I'm saying that is, please do not confuse comet tails with B lines, and especially if you're starting to score your B profile and make a diagnosis. Comet tails, in a way, are slightly different. And what you really want to define a B line is a line that completely extends right down to the base and kind of moves with the pleura. The comet tail will also move with the pleura, but it'll gradually fade. These are classical comet tails that you see over here, very small ones. Again, just giving you an idea of what different probes look like. So, I mean, really what we're using here at this particular point is a probe, a linear probe, and a very superficial part. So, we're just seeing a centimeter, but you can see the comet tails here, very nicely visible and disappearing. And classically, what you can see is what is an A profile. So it's really important. The presence of comet tails does not make this a B profile. I'm basically going to skip this slide. What I am going to say to you is that for us, really, image optimization is very different to how you image optimize when you do the brain and when you do the heart. So when we're doing the brain, the heart, even the abdomen, what we're trying to do is we're trying to get rid of artifact. That obviously means moving your probe, adjusting the distance, kind of changing gain settings. But really with lung ultrasound, what we're trying to make sure is that we don't attenuate our artifacts to the point where we then start getting wrong information. And that's why I would say to you that if you're using the wrong frequency probe, and a very good example is an extremely preterm baby, if you start using a sector probe with a frequency of 5, you're not going to get really good quality images. The artifact that will be visible will be very different to that's visible when you're using a high frequency probe, which really is going to interrogate the superficial areas of the lung much better. So for us, artifact is very, very important. What is very important is that we understand very carefully that image optimization for us will be at the level of the pleura, just below. And that really what we want to do is get a depth of about 5 centimeters in term babies and about 4 centimeters, 3 to 4 centimeters in preterm babies, so that we're seeing the whole of the lung to be able to visualize artifact in entirety. It's also important to kind of emphasize that there are some anatomical correlates. The ribs are anatomical correlates. The pleura is an anatomical correlate. Again, what I'd say is that when you have air between the pleura kind of doesn't slide. It's bright, but the pleura that's visible and bright is an anatomical correlate. The fact that it's not moving indicates that there's air between it, so it's not sliding against visceral pleura. That is an anatomical correlate. So it's an element of both, but to a large extent, what we're doing is we're dealing with lung artifact. So what we've done today is, if I summarize, is we've talked a little bit about the different artifacts that you see in lung, but what I've really focused on is what are A lines and what are B lines. Now, I would strongly recommend that you watch the videos around the generation of A and B lines. And in particular, before we go into nomenclature, which will be the class after the next one, you try and understand why we have different kinds of artifact and how A and B lines are produced. Because unless you understand this, you won't understand why you have B-line progression. And B-line progression is very, very important, because clearly when you have B-lines progressing, becoming more dominant and going to an AIS and a white lung pattern, what it's indicating is that your lungs have a lot of fluid. You have pulmonary edema. You basically have lots of fluid in the interstitial space, which is obscuring aeration. On the other hand, A-lines and the visibility of airlines is a marker of good lung aeration. In fact, for anesthetists who recruit patients, when you're kind of tubing and ventilating them, they actually have a score which basically scores A lines and B profile to kind of look at lung recruitment. And they score that from 1 to 5, depending on the classification you use. And really what it's looking at is the progression of A lines and their distribution in relation to B lines. So I'm going to stop there. Any burning questions? So I've got something in the chat. Anything? I would really love that you guys ask me questions, guys.
Hi.
Yeah.
I just want to ask about the Dropbox group for mentoring.
Yeah. So very good. Is that Anna?
Yes.
Yeah. So Anna, what I'd suggest is, I think we have 12 people who kind of want to have that. So this weekend, on Sunday, I'll be setting up your individual Dropbox accounts. This is in my Dropbox account. I'll be sharing a link with you. And my advice would be that you store your logbook there in an online format. Now, as you do your scans, what I will be doing is I will be adding a tick and be adding my signatures to that to kind of say you've achieved that level of competency.
Okay.
By the end of this course, there'll obviously be things that we've seen together that we have achieved. And then what I would say to you is the things that we might have to wait for. I mean, it's really interesting. We have, I've seen a lot of pneumothorax recently. Very interestingly, I haven't seen as much, TTN because we're not really scanning that many babies with it. It's so what I'd say is there's certain things that you will see that you will be able to kind of get very quickly. And then some things in terms of pathology that we might have to wait for. Trust me to say that the beauty of having the Dropbox is if you can anonymize the images, we can have a look at them on WhatsApp as well. And that kind of helps stick your competencies.
Okay, thank you.
My pleasure, my pleasure. Mayank, you have a question.
Yeah, thank you for the nice presentation. I have a query about bat wing sign. So is it only with the A-line profile that we can say a bat wing, or even if there are two rib shadows and in between there's a B line profile, then we can even call that as a bat wing appearance?
So what I'm describing here with the bat wing appearance is the ribs with a shadow behind them and the pleural line. When I say that you see visible A lines with pleural sliding, what I'm saying is that that is the normal lung appearance. Do you get the difference? So you could have B lines over here and the rib, so this rib profile with shadow behind it and this pleural line, that is the bat wing appearance. This is the bat's head, these are the wings. You could have a B profile underneath it. You could have B lines underneath it. You could have a pneumothorax there and you could still have a bat wing profile. But when you define normal lung appearance in a baby, what you're really looking for is a visible bright pleural line with horizontal reverberation artifact of A lines, certainly less than 3 B lines per intercostal space, and I would say pleural sliding. This is the bare minimum. Do you get what I'm saying? So there's the bat wing sign can be seen everywhere. It can be seen with lots of profiles. But it is the basic view that you have to get to be able to see the tissue, the artifact between two ribs. So for those people, for beginners who've never seen the lung before, really what I'd like you to do is get this profile through scanning, practice it so that you can see pleural sliding.
Okay, so bat wing sign can even be seen in pathologies.
Yeah.
Right.
Yeah.
Okay. And I have another query about shred sign. How is it generated?
Okay. Can I cover that when I do shred sign? Just so that.
Sure. Sure.
I mean, just in short, very short. God help me. This is a big slide. Yeah. Can you see you've got non-specular scattering kind of reflection? So when you look at the pleural margin with a shred sign, because I know you've seen it, what happens is that the pleura is very irregular. There is an area of destroyed lung below it. So it's an irregular margin where you have what is called scattering-based reflection. Because of the backscatter, you get this irregular kind of an appearance. And that's why you get the shred sign.
Okay. Thank you.
Anything else? I'm really sorry, guys. It's been a long lecture. Trust me to say, this one, the next one, and then it's downhill from there. But really what I would like you to do, guys, if you haven't done so, is please put a probe on the chest. Anything, just start scanning. I don't want you to be able to interpret all these things. Just try and put a probe on the chest and see whether you can just get the bat wing sign. God bless you all, and I'm really grateful. Thank you so much.
Thank you.
Thank you.
Thank you.